So I'm just going to go ahead and say good morning to everybody. Some of you have met, some of you haven't. I'm Debbie Dingell, Congresswoman from the 6th District of Michigan, co-chair of the Cancer Prevention Caucus, and cousin of a couple of people in this room, actually, to tell you the truth. So, and Bill always asks me to come and kick you off as you talk about issues that are really, really important. And cancer prevention remains more important than it ever has, quite frankly. We had the moonshot. We've been making progress. We've been investing in research. We also, today is February 4th, and we always do a resolution to call that Cancer Prevention Day and National Cancer Prevention Day, and we celebrate that, and we're getting that in. But I also think that you're here at a very interesting time at a crossroads. I was home for the last 10 days and spent a lot of time at the University of Michigan, which has $5 billion in research grants. $4 billion of them are from NIH and NCI, and they've all been frozen, and people don't know what's going to happen. I probably shouldn't say this. I'm not being political, but I am, in the sense that we got this bipartisan caucus. It's got to be bipartisan, and we got to work together on all of this. But I met with an NCI researcher who had a drug trial for cancer, whose prescription said make sure the participants in the trial reflect the population, including minority communities, and was fired for DEI. We cannot squelch research that needs to happen. We have to make sure the money is continuing to be invested. And I'm going to say to all of you, we can. I live for the day. I hope it happens in my lifetime when we actually find cures we are finding cures for some cancers, continue to find cures for cancers, but even more importantly are educating people and addressing the chemicals, the environmental factors that are causing cancer. So, as you're talking to people, make sure they know how important this is, that you can't play politics with people's lives, that research makes the difference. It does prevent cancer. And thank you for being a member of this caucus. Thank you for caring and being here today. Make your voices loud and clear and tell people about the work that you do and how it saves lives. Thank you very much.
Representative Dingell and all of our legislators today, they're all drinking out of fire hose. They're doing what they can right now to really save lives. One or two of you have said, wow, it looks like there are less people here this year. We're missing some of our partners at NCI. We're missing some of our partners at NIH. We're missing some of those partners that have been doing life-saving research because they can't be part of these types of events for now. But Less Cancer's role is to work with everybody. Our mission is less cancer, and it means less cancer for all. So now this is a different, more challenging time, but we are grateful to leaders like Mrs. Dingell and this event will be available online. Several legislators have sent in videos. But Mrs. Dingell can't because she's a sponsor and she's our fearless leader, and she's really single-handedly has helped change the landscape on cancer. So we're very grateful for your leadership. Grateful. Thank you so much. Thank you. So we're now over 20 years of doing less cancer. And this has really been an event where we've had to pivot this workshop. Every year it's seemingly different. We had COVID where we were online. Last year was really kind of our first live experience. And then we put this online where tens of thousands of people from all over the country will listen to this conversation. It's an important conversation because we know that when we can have these discussions, people they may change. When we talk about screenings, for instance, people think of going to get screened. Lives are saved with these conversations. So we're grateful for all of you being here. And we're grateful to our panelists and our board members for really leading less cancer. I'm not a scientist, I'm not a doctor, I'm not a healthcare provider. I'm just a guy like everybody else that wanted less cancer, right? So, but we are guided by lots of evidence, lots of science, and great scientists. Some of them are here today. And so it's important to remember, especially for students, that it's okay to have an intention like less cancer, but it doesn't work unless you have the evidence, unless you've done the homework, unless you have the science, unless you have the reality of what it means. So none of this happens without science. We desperately need our scientists. They are who save lives every day in this country. So I'm going to turn it over, Miles.
All right, Bill, congratulations on your work. You do great work. And, prevention and public health have never been priorities in this country, despite Bill's best efforts to change that. It's not the way we think. I don't know if you saw the New York Times this morning. It was a piece on why Americans are so wealthy and yet so unhappy. I invite you to read it. We're by far the richest nation ever conceived by humans, and yet we have the lowest life expectancy of any rich nation. We have a high murder rate. We have the highest fatal drug overdoses. We just are not focused on public health here in this country. And that is before this city became occupied and in the midst of a lawless coup, which is what we're dealing with right now. So how on earth can we continue to advocate for what people care about when NIH funding is just summarily stopped? It's a big challenge, but it's incumbent upon all of us who feel that this is a priority to keep talking, to go to the barricades and be part of the resistance, frankly. And that's what this panel is all about. This is a group that is focused on advocacy, and I want to make sure, as we not avoid the 800-pound elephant in the room. Let's face it, on the other side of Capitol Hill today, there'll be a vote, even probably as we speak, for a secretary of HHS, which would have a dramatic impact on public health and disparities in health outcomes. An HHS secretary who stands to make money on casting doubt on the efficacy of vaccines, which is an extraordinary statement. So what do we do? How do we operate in this environment? This group, I'm going to hopefully lean on this group for some answers. And I'll tell you what, let's do quick introductions. I'm going to have everybody introduce themselves quickly. And then I think before we get too deep into tactics in this weird environment, I'd like them to share like one story of success that they've had over the years, just so we can remember that there are victories that we are after. So I'll start right here to my left. And Tricia, why don't you introduce yourself?
Thank you. I'm Tricia Petzold. I'm a family physician from Salt Lake City, Utah. And I am the director of Health Promotions Integrative Health at the University of Utah Medical School. I teach a course called Culinary Medicine. And Bill asked me to be here to talk about food as medicine. And I'm the chair of the board of Less Cancer, and that's a big honor for me. So I would say the success I've had in, we'll get more into what culinary medicine is and food as medicine is, but the success I've had in the last 2 years is we've moved a 8-week elective in using food as medicine and teaching it to physicians and pharmacy students, nursing students, social workers, to a core part of the curriculum at the medical school. And so that was a big step forward, I think, in preventative medicine.
Hi, everybody. I'm Kelly Hirko. I'm an assistant professor in the Department of Epidemiology and Biostatistics at Michigan State University at our College of Human Medicine Rural Campus, which is located in Traverse City, Michigan at Munson Healthcare System. So my training and background is in cancer etiology and modifiable factors for cancer prevention, and trying to understand how those modifiable factors also contribute to disparities. But in my current role since 2016, I've really shifted a little bit to focus on how We can use implementation science approaches, which is taking the evidence-based interventions that we know work to prevent cancer and address disparities, but to make them work in under-resourced settings like where I work in a rural oncology program. I guess success is, it's hard for me to think because I'm starting to go through some of my projects and I feel like they're all still works in progress. But I think one success that we've had, I work with medical students from our rural program at Michigan State. So most of the 3rd and 4th year medical students who are on our rural campus want to practice rural medicine. And through our program, we've developed a telemedicine curriculum for our residents and our students to learn about what some of the challenges that our older rural populations face with regard to digital literacy and access to telemedicine to try to overcome some of the barriers and address the healthcare access barriers in our rural region.
So I am that girl. I'm Linda Reinstein from Los Angeles. Don't hold that against me. And Bill, I'm delighted to join you today. This is an important day. It is not just a day. It will become a mantra. Prevention is the cure. My husband, Alan, was diagnosed with mesothelioma in 2003. Like so many other Americans, we'd never heard of the disease and soon learned it was incurable. He fought for 3 hours. He fought for 3 years and died in front of my then 13-year-old daughter and me. And the lesson for that is not for sadness and condolences. It's to understand that the work that you do today and this panel is important to prevent cancers. And that is what we can do with knowledge, advocacy, and obviously collaboration. Miles, you know a lot of my story. So the successes for asbestos prevention and elimination have been difficult because it's been a known toxin for over 100 years. We've made great strides because of collaboration and data-driven science and storytelling, but we still have more to go. We implemented ADO and other colleagues. We worked to implement the Frank R. Lawton Bill Chemical Safety Act that was signed into law by President Obama in 2016. But just because you get something signed into law doesn't mean it's snap done. So we spent 10 years trying to implement it, which successfully EPA did ban 1 of the 6 asbestos fibers in 6 conditions of use last March. And I tell you that information because there's a special on next week on the 10th that will talk about this. And what does that mean to you? It looks like a big legislative victory, but there's more to be done, and it now sits in the 5th Circuit Court of Appeal. Along with other successes, I feel that having Congress and people like Representative Dingell recognize that cancer prevention is a top priority. The Alan Reinstein Ban Asbestos Now Act, which was introduced in 2016, will be reintroduced in the next few weeks again. Why does it take so long? I don't want young students and leaders to be obviously disillusioned, or more importantly, walk away, because we need you. You are the future. And then lastly, I think working on panels and collaboration, like with Less Cancer, you follow the leaders and you work collaboratively. There is no winner at the end except for good feeling that we have prevented cancer. Before we pass the mic to my colleague, how many people here have personally had cancer? If you feel comfortable answering, raise your hand. Thank you for coming. How many people here have had a family member or a loved one that has had cancer? So we're not alone. We all speak the same language, and I look forward to this dynamic conversation. Thank you, Miles.
All right. Thank you, Linda. Monica?
Good morning. I'm Monica Baskin. I'm a professor of hematology oncology at the University of Pittsburgh School of Medicine. I also serve as the Associate Director of Community Outreach and Engagement for the UPMC Hillman Cancer Center. I am delighted to be here today and be among this esteemed panel. And, really wanted to share with you one of the successes I think that we've had historically. So prior to coming to Pittsburgh, I worked at another NCI designated cancer center, and I'm really proud that we were able to show that we could train local community members through a community engaged process to give key messages around lung cancer screening and prevention to educate community members in their local areas in rural Alabama, to tell them about why it mattered in terms of having early detection of lung cancer, speak to them about what the criteria were in terms of being eligible for that screening. And then we were able to, with our staff, navigate those individuals who were educated and interested to get a low-dose CT scan. And so what we know nationally is that a lot of times people are being diagnosed with lung cancer at stage 4, when we don't have as many wonderful options and the cancer survivorship rate is very low. We know if we get them in at an earlier stage, the survivorship, is very long and people can live a long and healthy life. So nationally, in terms of those who are eligible, a minuscule 4 to 5% of individuals actually go on to get that life-saving screening. We were able to go from that national average or even the statewide average to get 25% of the people that we educated to actually go ahead and get that low-dose CT scan. And we certainly found people who had cancer, and we navigated them on to treatment. So I think that, my success story here is just talking about, as one of my colleagues or multiple of my colleagues talked about, collaborations. So we trained local individuals. It wasn't our team that was coming from the cancer center that was going out. We trained local individuals about key health messages, about why it was important, how, if they were smoking, how they could get involved in smoking cessation programs. And then the key there was to navigate them to that facility, sometimes driving them, sometimes walking hand in hand with them so they felt comfortable with that. And they actually went ahead. People said, you can't get that possibly done. The other part of the collaboration, it was an NCI designated cancer center, so funding from NIH to support our infrastructure, but it also was funding from the Go-To Foundation that was really focused on how can we do this collaboration. So now in my new home state of Pennsylvania and in Pittsburgh at the UPMC Hillman Cancer Center, we focus on the 29 counties in Western Pennsylvania. There are a number of people from all walks of life who are eligible for that lung cancer screening who are not achieving that and not getting that. We have lots of community-based clinics within UPMC where people can go and get the screening, but there are some key elements that they're missing. And so what we're doing now is we're transitioning that same program. We've brought in community health workers in 4 of the counties where we have high rates of lung cancer as well as late-stage diagnosing. And we're training those individuals to be the ones that go out. They know the local culture. They know who people listen to. They know the language and the way to communicate and what channels to communicate in. And we are expecting to see similar benefits as we transition to Western PA.
So, Monica, I'm going to stay down at your end of the table. Are you concerned about funding drying up that enables a lot of this communication? Much of what you do is get the word out to people who don't know, right?
Yeah, I think it's critical. I mean, there is a lot of interest in local communities and certainly among scientists and clinicians to do a lot of the great work. Again, my colleague mentioned about, implementation science. And basically what that is for all the strategies that we know that work, they're fantastic. They make for wonderful publications. They help other scientists to get more grant money. But one of the things that we know from our research is that many of those interventions and programs are not being disseminated in the communities that can benefit the most. So funding at all levels, federal level, local foundation level, state level, county level, is important to make sure that the evidence that we have that can save lives, prevent cancer, that those programs are going to the communities that can benefit the most. I will say for myself and my family, we are quite fortunate that we get all of our age-appropriate screenings. We don't have a problem with that. But I know tons of people that don't have those same, privileges. And so we need to make sure that those communities have the same access that I and my family have for that screening.
So at the federal level now, DEI has become a 3-letter word, which nobody wants to utter. To what extent, how is it possible to address the very health disparities you're working on if you're not considering DEI?
Yeah, so I don't want to speak because I don't know how individuals might define that. But what I focus on as an individual researcher and the work that I do is exactly what I just mentioned. Everyone deserves access to the highest quality of care so they could live as long as possible. And you cannot do that by only focusing on one population or one segment. And so we are a very diverse nation. The work that we do within our cancer center represents, again, 29 counties. That includes probably every person you can imagine from every walk of life. Cancer does not discriminate, and so neither do we. So we are trying to get out there and make sure every single person has that access. But we do know that some people don't have the access right now, and that's where I think we're turning our attentions to. As I mentioned in my personal story, my family doesn't necessarily need these interventions because we have the access. So we're going into places, maybe in some of the rural populations, lower income populations where they're not knowledgeable. And that's where we are focusing our efforts on. And that takes resources. So we have to have the resources to be able to do that. So from a researcher standpoint, absolutely, making sure that there's sufficient enough number of research dollars out there so we can learn what works for whom and get those interventions into the communities that can benefit the most, I think is really important.
Kelly, you also work a lot on disparities. And one of the greatest tools for public health are vaccines. And there's a lot of confusion about vaccines, to say the least. Does that come into play on a day-to-day basis in your work?
It does. There's a lot of, in general, mistrust, particularly in a lot of our rural communities when it comes to governmental organizations or recommendations. We've done some work to try to understand who's the best messenger to promote some of the evidence-based cancer prevention strategies, and it's often not those coming from the government, right? And not what the government tells you to do. So it definitely comes into place. I don't personally work a lot in HPV vaccination. We have tried to promote HPV vaccines working with our pediatric providers in our community. And I know from working with them that there is a lot of concern. But I think, it is really finding out who do you work with in the community? How do we get that message tailored to address the needs and the barriers and the preferences of that community in order to increase uptake in the communities that are not currently up to date with the recommendations like others?
Give us a sense of some of the challenges of communicating this message to the communities you focus on. I mean, we all assume everybody's reading this thing, and that can be good and bad, right?
Mm-hmm. Well, one example, it might not be exactly directly in response to your question, but I think it's related enough. We built a beautiful cancer center in 2016. It opened in 2016 at Munson Healthcare, and it had a beautiful health and wellness suite with free oncology certified fitness trainers available to provide a physical activity program for anyone during their cancer journey. So from their first diagnosis, after treatment, through survivorship. And we wanted to assess quality of life outcomes. We knew that physical activity was beneficial not only in cancer prevention, but in prevention of recurrence after initial diagnosis. And we started providing a survey to people who were participating in this program, and it took years and years and years to get people to participate in this program. And we published the results. We had about 40 participants, I believe, who participated in at least 5 classes. As expected, we saw the improvements in fatigue and pain scores and some of the emotional health outcome measures that we expected. But our big take home from that was that less than 1% of the people who were eligible to participate in that program actually did participate in that program. So our messaging, our communication.
Less than 1%?
Less than 1%. It was 0.33%.
Wow.
So the lesson there was that, we have this program that works. We've seen it work in other settings, but in a rural area where we have people driving 200 miles to receive care, this isn't a system that's going to work, right? And so our messaging and our communication strategies have to be tailored to address their needs. Our interventions have to be adjusted and adapted and refined in order to be still effective, but actually feasible and acceptable to our populations.
Well, that's easier said than done. When people are driving 250 miles, what do you do?
We're still in the process of actually going to the community, and that's what a lot of our research now is doing. Instead of assuming that we have the answers from these evidence-based programs, we're asking people, what kind of programs do you want? What are your barriers to participation in physical activity programs? So we are doing that work now. We've talked anecdotally about using digital technology and telehealth that has worked in other settings. It's really challenging in our setting. Our population tends to be older, has sometimes not even broadband access at home. Some people don't have the digital literacy to feel comfortable using a digital platform. So I think, unfortunately, it's not a one size fits all, and we're gonna have to have different options that meet the needs of the people.
All right, let's move into the environmental causes of cancer. And Linda, you, you lost your husband in 2003, right? And you've been walking these halls almost pretty much ever since. So the amount of persistence and perseverance that you have exhibited is extraordinary. And yet, I think a lot of people are still unaware that, the stuff, asbestos, which people get in moon suits to take out, is still legal in this country. What do you think is going to finally change that and finally lead to an outright ban? I mean, clearly there are economic interests here that you're up against.
Well, that's the million-dollar question. So let's step back for environmental. So in the 70s, 71, we had President Nixon declare a war on cancer. So we're 50 years into knowing what carcinogens are class 1, et cetera, and we're still behind EU, like my colleague spoke about. So one is...
Well, it might be worth telling about the precautionary approach that the EU takes. That might be, I don't know if you want to get into that.
It's elaborate.
Is there a short way of describing? All right,
Well,
all right, never mind.
How about they do it right, we do it wrong?
Okay, there you go.
They have
They presume
Yes.
the burden of proof is shifted, put it that way, about a new chemical.
Absolutely. So let's think environmentally, and let's think about vulnerable populations. So as far as asbestos go, it's highly litigated, always been contentious, and if you can hide information, suppress documents, not link the science, create doubt, you can exacerbate an environmental disaster. So we are working with unions like the International Association of Firefighters and others. And for those of you who have been watching the news, you couldn't have missed that my city's been on fire. The beaches have been closed. Miles, you've been out there. It will take us decades to clean it up, and there will be exposures along the way from asbestos and other heavy metals. So environmentally, learning from what did work with asbestos prevention and policy to what hasn't worked, I think enables young advocates to better understand what tools should be in your box. Because why are we still talking about asbestos? Aren't we done with this? I estimate 9 out of 10 Americans think asbestos has been banned. And if you can't see it, taste it, touch it, smell it, wouldn't you think the same thing? And if a company exposed a group of workers or communities of asbestos and they became sick, they're financially responsible. So it's been my greatest pleasure to take euphorically a pot and pan and go to vulnerable communities like in New Orleans and have community meetings and get people together, because cancer can be a very scary word, and we have to demystify cancer, understand causation, and get to prevention and treatment, or we're going to be talking about this when I'm long gone.
We would be remiss if we didn't tell everybody where you live in Los Angeles. Now, you're a little south of where the fires were, but the air quality has been dramatically impacted. And frankly, a lot of asbestos went up in flames there. And do you worry a little bit you're going to see some kind of cluster that comes out of this down the road?
I don't worry, I know. On Wednesday morning, right after the big fires on Tuesday, it was dark, and I always have my East Coast calls, and I went out for a quick walk. I didn't look at the air quality number, and my voice has literally changed to be hoarse and raspy, and you as a physician would be OMG because I went out without a mask. But if you don't understand these things, then you can fall into the cracks. And it's going to be a long road to recovery for LA. But it's not just LA. We have the Carolinas, we have Florida, we have the remnants of 9/11. So we can talk about occupational exposures, but let's think environmentally, because that is huge with legacy asbestos in structures. So if a home, school, or workplace was built before the 80s, there's a very strong chance that asbestos is in the walls, floorboard, insulation. But if you don't encourage and incentivize knowledge and abatement, we just keep telling the same story.
Give me a couple of words on the very real challenge of connecting individual health outcomes, mesothelioma, to asbestos. It's very difficult to connect dots in the political and legal realm. Have you made progress on that front?
Yeah, a lot of progress. But when you can't see it, and the carcinogen is kind of hidden, it makes these conversations more difficult. But the reality is, in the last 20 years, and yes, I keep banging my head on sharp corners, we have made progress. And you'll see now people in Los Angeles going back to their structures or their foundations, and they are wearing moon suits. After COVID, we understand masks can prevent exposure. So there's things along the way, and I use every opportunity to hopefully use my voice with the firefighters and others to raise awareness. And we work with Go To Lung Foundation, because prevention is secure. So when there's a knucklehead in Washington that would like to have a conversation about why it's hard to ban asbestos, I make sure I tell them the Grizzly Grim story and the truth, because we cannot have politics. We cannot talk about the cost. We have to talk about the people. That is what matters. And that's why we curated over 200 stories, and Bill was so positive about this book that we produce. It's 200 stories of people who've been impacted by asbestos in the United States. So this will be going to my meetings today and tomorrow, so they can see the undeniable truth about the impact of asbestos.
Yeah, I just was flipping through it. It's really, it's a tough read, but an important one.
Thank you.
Bill, do you still have a mic?
Yes.
Yeah, so your organization began with this idea of environmental causes of cancer and the difficulty of connecting the dots. In your case, it was pesticides and the death of your sister and something that happened next door to you. Give us a sense of how much of a challenge that was initially and whether that has changed at all.
So when we started, we were prompted by those exposures we knew caused cancer, prompted by unnecessary and preventable exposures. Made no sense to me that we could do something and not expect an outcome. So when this journey started, I sought out the best and the brightest scientists, because as I mentioned before, I'm a C student from Wayne State. And I was like, is any of this preventable? Can we lower risk? What can we do? And Dr. Herberman, who was formerly on our board, he since has passed away, said, Bill, look at the smoking. Almost 500,000 people a year die from cigarette smoking. Of course this is preventable. Of course we have the unnecessary and preventable exposures. So then that is, this 20 plus year journey has been not only an idea or an intention, but a great learning process. And the reason we know we need to have science, we need to have science as our guides and evidence. It's more than just what I think or what others think. We have to be guided by the evidence-based science.
Tricia, the challenge is, first of all, of educating people about the value of eating that faro bowl or that poke bowl, if you can, are not insignificant given the way the corporate food industry is developed in this country. Just give us a sense when you're dealing with your patients, what myths or misunderstandings you run into and how you overcome them.
I think barriers, obstacles. One is the overwhelming information, fad diets, extreme information we get.
Yeah, should we take that pill, by the way?
Yeah.
Ozempic? Yeah? Should we do it?
So let's go there later.
All right,
That's
we can do
too
that
big.
later.
That's-
We'll do the
okay.
console later.
And the other, of course, is time, is money, is education, understanding. So many people go to their doctor to ask what they should eat, and I got 4 hours. In 7 years of education, I got 4 hours of nutritional education. And that's changing.
That's it.
That's it. And so I think that's really a problem. It's a problem if we're not prioritizing it. And so that's where food as medicine, culinary medicine comes in. But in terms of just with my patients, helping them, one, in a busy lifestyle, how do you still eat well? How do you teach people to batch cook? How do you teach people to cook enough to freeze some and rotate that food back into their rotation? How do you those are the things I do. How do you help people buy food and use it all? And when it's going bad, use it, freeze it, and eat it later. Because food waste is one of our biggest problems, what makes food expensive. And then for learning what the resources in the community, what grocery stores offer better pricing for food, and that frozen fruits and vegetables are just as nutritious as fresh fruits and vegetables, and you can get them on sale, you can keep them, and you can use them out of the freezer and learn how to use them. And then helping people get a baseline understanding. And I think that takes somewhat of a foundational education. And personally, the way I do it is I offer an 8-week nutrition class quarterly out of my clinic, and it's very low cost, so people can get a foundation to how to become a critical thinker of what they're going to eat.
So what you're doing is kind of outside the healthcare system box, to say the least. Is it a challenge to get these kinds of programs into a system that is more about, dousing a fire as opposed to preventing it?
Yes. Currently, I mentioned culinary medicine, and this is sort of an exciting part, I think, of preventative medicine that's happening right now. There's 58 members and organizational members. Not all are medical schools. Some are libraries. Some are community organizations, and there's over 250 individual members of this Teaching Kitchen Collaborative. And basically, we've taken chefs, physicians, and social workers and put all those brains into one approach and say, how do you figure out what people need to eat from a nutritional science point of view? How do you make it unapologetically delicious, as only an artistic chef would do? And how do you help people identify their barriers and get off the fence of what they want to do, and how to make something sustainable from a motivational interviewing behavioral science point of view? And that's basically what culinary medicine is.
So when you talk about food as medicine, what are your metrics for success? It gets a little bit more challenging, right? It's a little more subtle than giving, some sort of strong pill of some kind.
Yes, but more effective. More effective. We know.
Is it hard to prove, though?
Nutrition research is hard because there's so many multiple factors to it. When you eat, there's so many multiple factors, and what you eat is over a long period of time. And so the duration of the studies make it hard to do as well. We do know that almost all our chronic diseases are created or worsened by food choices. 60% of the children now are estimated to develop diabetes
60%.
by the age of 35.
That's nationwide.
Nationwide. And 12.8%.
Why isn't that like a national emergency right there? Right?
It is a national emergency. And really, 12.8% of households experience food insecurity. And we know that nutrition and food insecurity contributes to the pathogenesis of chronic diseases, diabetes, heart disease, certain cancers, most of the top 10 leading killing diseases in the country. And we also know that nutrition, nutrient-dense, whole foods, good healthy fats, lean proteins, avoiding ultra-processed foods and saturated fats and added sugars can reduce those risks. In fact, it can prevent, manage, and reverse diseases that our pharmaceuticals can't do.
So the whole foods diet, for lack of a better expression, is a good diet, but it's more expensive, or at least that's the perception. Is that wrong? I mean, is it just the way our food is distributed and sold? Or is it more expensive to eat healthily, and does that make it a difficult thing for wide sectors of our population?
Yes, it can be very expensive to eat healthy, but on the other hand, part of that problem is our time, our food waste, and not knowing that you can use frozen foods or freeze your produce and have the same nutrient advantages from it. So look, there's a big education problem. When we teach our culinary class, we'll feed the room of 25 a incredibly delicious meal for $150, and we have 25 students. So
Good.
And that's buying appropriately, not wasting food, and knowing how to season it.
So, Monica, Tricia was just talking about getting chefs, physicians, and social workers all in one room. Yeah, there's probably a joke we could do. Yeah, they all walk in a bar or something. Anyway, but the point is the multidisciplinary approach. I mean, let's face it, we live in a stovepipe world, but that idea of bringing those groups together seems to me to be a very potent potential force. How do you approach it from where you sit, as far as reaching across outside of academia or healthcare, whatever in the case of Linda, advocacy?
Yeah, thanks for the question, and I think it dovetails very nicely to this conversation about food and medicine. So one of the things that we were able to do is a demonstration project. Again, it was in rural communities that did not have access to larger grocery stores that have those wonderful rainbow of produce available at a reasonable cost. And I'm not sure about any of you, maybe it was just my bias, but growing up in an urban area, I always thought of rural communities having lush, access to all kinds of produce and everything you needed. So I didn't understand that there are tremendous food deserts in rural communities, because our country has really moved more towards these larger industrial farms, not the usual family farms that many of us maybe grew up thinking about. So what we were able to do, we pulled together people, like you're saying, from all walks of life. So not only psychologists and behavioral scientists like myself, but some of our physicians, our allied health professionals, and we developed a demonstration project where we were also collaborating with Cooperative Extension. And so Cooperative Extension had Master Gardener training programs available. And what we did was we matched Master Gardeners in some of the rural communities to go and work with individuals that we were bringing into a weight loss program, and partnered with them to train them to actually create, vegetable gardens in their own home. So they got containers together. We gave them soil. We gave them all the ingredients to create their own garden, so that they were producing their fresh fruits and vegetables in their home. And so that increased their access. What we demonstrated is that not only did they increase their access to those healthier foods, but they got more physical activity, because getting out there, working and tending in those container gardens was really helpful. And they contribute to the economy of their community, because we then, for every master gardener that was trained and went through the program, they were then made available, and then they had other opportunities to connect with their community. So that community engagement that I think most of us have talked about in bringing people from different walks of life, we were able to take a problem that was in the community, but also think of a community-led solution. And I think that's really critical. So I think for me, all of my research, from the very beginning, has been bringing people that have different backgrounds as mine, different disciplines together to address some of the difficult problems that we have. So social determinants of health are really, really difficult to move. I mean, I have to believe that, within our federal government and everybody, if it was easy, we would have done it by now. It is very complex, and I think that's why you need those diverse teams around, so that we can come at it in different ways. So it's not just a healthcare issue. It's a transportation issue. It's a housing issue. It's an education issue. It's a economic issue. And so having people at the table really makes a difference.
The system is filled with all kinds of perverse incentives. You know, when you look at how agriculture has evolved in this country, I was in Illinois last year on a farmer in an area talking to a farmer, and there's no vegetables, there's no produce, there's not even a dairy farm. It is 100% corn because farmers are going to grow what they're going to make money doing, and so they have this incredibly rich, wonderful soil producing this monoculture, and they don't have any healthy foods available to them in their own garden. It struck me. I think we all assume that the family farm still has a variety of output, but it really doesn't anymore, does it?
No.
Who else wants to talk about multidisciplinary? Kelly, do you want to talk a little bit about how you reach across the stovepipe, so to speak, to try to create a little bit of a force multiplier?
Yeah, I'm just thinking in these conversations about my own community and what I've seen. And, a lot of my research historically has been on how does diet and our dietary choices impact breast cancer risk and different types of cancer outcomes. But when it comes down to it, what are people going to do with that information if they only have a Dollar General to go to get their foods? And that's what many of the rural communities where I live, that's where they get a lot of their foods. I traveled this past summer just 20 miles from my house to the Grand Traverse Band of Ottawa and Chippewa Indian Tribal Reservation, and was touring the reservation with my wonderful colleague from the Intertribal Council of Michigan, Beth Seeloff. And she was showing me the gas station and the casino, and that's where people get their foods. And if they want to come into town to the grocery store, it is a over 30-minute drive. So, we can have the evidence, we can know what people should do, but when our systems are not structured to make the best choice the easy choice, and even make the best choice accessible, in a rural community, I sometimes get to go to the farmer's market. It's more expensive than the grocery store to get fresh produce, even in a rural area, right? So we do need people working together to create the structures and the systems and the policies that make the healthy choice the easy, the affordable choice for people.
In the real world, though, it would be better if they got in the car and drove 30 minutes. How do you convince them that that's a good idea? That's a big challenge for people who are economically disadvantaged, and for all sorts of reasons. It's easier to go, get the burrito and fire it up in the microwave, right?
Mm-hmm. Absolutely. And in my conversation with my colleague in the tribal community, it's a lot of the tribal elders that live on the reservation, so they even have physical limitations to leave the home. So, we've worked with Meals on Wheels in our community. We did a Food is Medicine project where we partnered with Meals on Wheels to try to reduce hospital readmissions by delivering tailored foods after a hospitalization. And this is an example of, this is something that the hospital cared about because they were getting penalized for readmission. So if we can say, let's try a nutrition program partnering with Meals on Wheels, and it actually benefits you and it benefits the community, then let's make that work. And I think that's what it's going to take to make these efforts sustainable and make them reach the people who really need them, is to have the policies, the structures, the systems in place to support these efforts long term.
So, Bill, you've spent a lot of time trying to bring together a lot of experts from various sectors to address problems. Is that the way to go?
I was speaking in an area to a homeless group of people, and I asked the question. There was a great soup kitchen that really honors their guests down the road. They grow urban, organic food. They do amazing work. And I was like, who's eating that? Somewhere. And I was like, well, who's eating across the street at Popeyes? And this woman said, don't judge me, which was really smart for her to say, because I was thinking in my head, it doesn't make sense to me. It didn't make sense to me in my world. But in her world, she explained to me she lived in a homeless shelter with her children, and it was the only thing that made her children feel normal, that didn't make them feel homeless, that didn't make them. And we spend billions a year billions marketing to populations like kids and other health-affected populations that impact them in very negative ways. But from my perspective, I didn't even think that was going to be an issue. I thought she was going to say, oh, it's too far to walk, or something else. I had no idea Popeyes could make anybody feel normal. And so, but to a kid, I get it. It looks pretty magical on TV. I get that now, but I hadn't thought of it. So I think as we collaborate, we learn more about people's perspectives, how they interpret information. Things shouldn't just be assumed. And so it's a complex measure. There's no one answer. There is no flip of the switch, which is why this conversation has been going on for decades and why we've been working towards these goals. And it's a matter of understanding, not necessarily blame, but understanding and putting these structures together. And we do this by collaborating, speaking to each other, learning from each other, even the unlikely thinkers, people we don't agree with or from the same political party. That's how we get solutions. I'm sorry.
Excellent. Yeah, Linda, how do you collaborate?
Thought on that. I think we have to identify the big why. When it comes to multidisciplinary groups, you have to understand, why is asbestos 100 years later still a problem? So working with physicians and surgeons, et cetera, became a really great spot. And then teaching medical students, how many hours of OCMED did you get in med school? Some people tell me 15 minutes. So if we can't reduce the barriers, increase the conversations, and draw in and speak to people in a way, or actually talk with them and listen about their big why, not just ours, we can't make the progress we want to make. So I found working with the medical community has been really terrific. And we do congressional staff briefings. I always bring in a white coat, not to offend anybody, but I bring in a white coat. My thoracic surgeon from Mount Sinai comes down, and you know what? People sit up straight in their chair when a physician speaks. And I think it's very important in advocacies to have the data-driven science that backs up your message, but bringing in the medical community is huge. So we'll see what Cassidy does on the Senate side, but it's big. And the part about culinary medicine, Trish, I think is fascinating. It would be interesting to me if you do culinary medicine for a cancer patient, because your taste buds, your life, your world changes, and your family structure might also change because of transportation and undergoing treatment. So culinary medicine, to me, goes beyond just getting healthy. It's where you are in life with your health conditions.
They know today that prevention is the number one reason lives are saved for people under cancer treatment. Some of that programming is already happening for cancer patients. But the chronic disease issues, when we hear numbers like 60-some% of people are going to be diabetic, is insane.
Yeah, I think that's a great point. We just put a demonstration kitchen in the Huntsman Cancer Institute. We have demonstration kitchens and teaching kitchens throughout the University of Utah. And so we'll bring patients in.
I love that.
We'll talk about it. There's a cancer fighting cookbook that I use a lot, which I love how she fills it out, where people say, I don't have an appetite, and there's certain herbs, spices, foods that stimulate that. I have nausea. There's certain, same thing. And so we can design a meal to try to combat some of those symptoms, as well as bring down inflammation, reduce the chance of recurrence, help them get through their chemo treatment. And it's really specifically addressing a disease state is very within the realm of culinary medicine, whether it's diabetes and trying to manage blood sugars, whether it's cardiovascular disease and trying to get healthy fats and lower cholesterol levels, whether it's cancer and trying to reduce inflammation and protect the immune system.
I love that.
So that's great. And that's a good point. I was talking about teaching a student in a culinary kitchen, but really bringing patients in, breaking down their barriers, seeing what they are. Is it comfortable to hold a knife? Do you know how to cut a tomato? Or is it you can't get the vegetables because you're in a food desert? You don't know how to shop.
I barely know how to shop.
Well, there's the cognitive energy it takes to be creative, and so that is an intimidation for some people on getting over.
20 years ago, I was at Children's Hospital of Michigan watching a young family bring their child home with a port in it, knowing that the only liquor store nearby, the only food store was in a liquor store nearby, the only place to buy groceries in Detroit at that time were really liquor and convenience stores. So I say to the guy at the hospital, wouldn't it be great to have a grocery store on this campus? Oh, that's crazy. We're not in that business. Well, today there's a Whole Foods. They're buying foods locally from an urban garden. Nutritionists are shopping there. There are opportunities for people to learn about their foods. So we make assumptions people know. And quite honestly, in this world of ADHD, here again, I go into a grocery store and I often look at a sign that says, buy me, and I do that, and then I wonder where the bathroom is, and then I'm out the door. So, this idea of reading labels to the most educated is pretty out there, in my opinion.
Can I just?
It is what it is. Go ahead.
I just want to pipe in. I know it's probably not going to be a popular statement, but one of the most consistent dietary factors associated with cancer is alcohol consumption. People don't talk about that. Yeah, I mean, breast cancer, alcohol is a very consistent risk factor for breast cancer and other cancers, and that is something that most people aren't aware of. So I think that should be part of our conversation too. That's a modifiable risk factor. Even reducing alcohol consumption can have a big impact, particularly for breast cancer.
I think the thread that runs through all of you as you talk is the lack of awareness and the lack of public engagement on the issue of prevention, right? You've got people tend to focus on treatments. Corporations certainly focus on treatments because that's where the money is, quite frankly. People don't really understand the environmental and other risks of cancer very well. They don't understand risk very well. They're more worried about a plane crash than driving in their car, where they have much greater chance of getting killed doing that. And the other thing is, too, you're talking about, we are a quick fix nation. These are long-term things you're talking about, changing your diet, drinking less, all these exercise, on and on it goes. So I'm going to start with you down the line there, Monica. If you could tell us what your advice is on how to raise awareness and engagement on this. This is, after all, what Less Cancer is all about. But if you have some thoughts on how to get people to listen to all this, we're all ears.
Yes, so I'm a psychologist by training, and then do behavioral science work, cancer prevention and control. And I mentioned, one of my titles is Associate Director for Community Outreach and Engagement. I think, especially, in the climate we've been in the last, 18 months more, I think it really does start with relationships. And what we refer to in the cancer space is bidirectional communication. So I think it's more about listening than talking, but I do think it's sitting down. Bill's example is a perfect one there of just having a conversation with people, finding out what their everyday lived experience is, what do they need. And for many, cancer prevention is not at the top of their list. And we need to sit and hear that and hear what that list is, and to the best of our ability, connect them with what resources they need at that point in time. So I think it's less of a public health model where we're trying to get the masses. And I think we need to go back smaller in listening to individual communities. One community is not going to have the same needs and issues as the next one. So I think we've got to stop talking at people and start listening and co-develop programs. So I think the successes that my team has been because we have co-developed programs that are in their local communities that address the local needs. And we hire local individuals as the ones that are out doing that program. And so it helps in a lot of ways because it's not only addressing the health issue, it's addressing some of the issues of lack of employment or lower employment. They become, employees of a very large organization. They get health benefits. They get other things that are associated with that. And the employers are excited because, again, prevention, even if you're not for the altruistic reasons around why you do this, there's an economic benefit. We know when people have cancer or when they are caretakers of people with cancer, they're you have high absenteeism rates for either going to their own appointments or taking everybody around. Employers incur a lot more heavier costs in terms of their portion of healthcare benefits. So starting small, figuring out what's needed in that local community is what I would suggest, but it's going to have all these other impacts on everyone else in the community as well.
Linda, what are your tips on getting people's attention? You know, these are all kind of David versus Goliath stories, right? It's you versus, you know, a very profitable industry and an EPA that may not be paying attention, and there's an onslaught. So how do you cut through all that and get your message out?
I first have to get in the door. Once I get in the door, it's a little easier. But yeah,
You go in a few windows.
through the ceiling.
You're so shy and retiring, you know.
I'm a widow, so my barriers have been removed with Alan's death. So my fear is gone. I have a 31-year-old daughter, and I want to teach her to be effective. What do? You have to meet people, for me, where people are. Have that conversation, be non-threatening. Talk about why cancer prevention matters. What do you think it costs to treat a lung cancer patient from beginning of diagnosis to treatment to death? Mesothelioma is about $1 million. Isn't it worth investing in prevention? I think building relationships, which has all been spoken about here. Gratitude is a very big part of my currency because I don't have money. I run a nonprofit. So using gratitude to get to yes has been really important, but it has to be genuine. And it is. I'm always appreciative to members of Congress and the medical community for listening on prevention. But most importantly, if people understood that you could start today on an active cancer prevention program, whether it's for asbestos or other issues, you can make a difference. We have this mindset that once you get diagnosed with cancer, then you just need to become this cancer survivor. Well, sometimes that language doesn't work. So being a warrior, a thriver, whatever the language works for you, we have to start in that spot and then look at the opportunities with optimism and reality. Because cancer is terrifying, and mesothelioma is outrageous to know would have been preventable for Alan. But you know what? It just pissed me off enough to never go away till it's done. And I think that's important for advocacy and for meeting people where they are.
So we need more pissed off people, probably, right? Yeah, probably.
Less cancer is
building them by the minute here.
But the work that Less Cancer does is so important. And not to bring up a personal thing, but I know you know from cancer that once you get that diagnosis, your world changes forever. It's not just the patient, it's the entire family. So thinking holistically has also helped our messaging.
Kelly, what are your messaging techniques? What's your advice to try to get people's attention and move the needle?
I couldn't agree with what's already been said anymore. I think it's so important. I feel in my role as a community-based researcher, it's really important to raise up the voices of those who haven't been included in the cancer prevention space. When you look at rural, I keep talking about rural because that's where I work, but only 4% of NCI grants in the most recent portfolio analysis were funded for rural cancer control programs, when we know that cancer mortality rates and cancer incidence rates are higher in our rural counties. This also means that the most of our cancer research and interventions are being developed in high-resource NCI comprehensive cancer designated centers that are not going to necessarily translate into the under-resourced community oncology programs where the bulk of people get their care. So we have to work with our communities to know what their priorities are and know what we can do to help work with the community members who are recognized, who are valued, who are champions. I think a lot of times it is the providers in the community, but who are those champions in the community that can bring the awareness and work on the priority areas for the community, instead of us coming in to say, we want to reduce your alcohol consumption, we want to increase your fruit and vegetables. It's really starting with the communities that are, highly burdened by cancer and saying, what can we do to help? What are your priorities? And in my community, it's a lot of environmental concerns that they feel are completely dismissed when they report cancer clusters, and in my area, it's a lot of cherry orchards, so there's a lot of concern about pesticides. So if we ask the community, we might get a lot different answer than actually what our research is being funded on in the NCI designated cancer centers.
So the urgency of the problems frequently is it's more urgent than the pace of the research and the findings you get. So what do you do in that case? You don't want to get too far out ahead of your skis, but having said that, you want to save lives too.
Yeah, and I think we need to be creative because the current scheme for funding, it takes years to get even your grant funded to do the research, right? And by the time your grant gets funded, your idea may almost even be obsolete. Or, I know studies that are still being published and presented at conferences that focus on DVD educational interventions. So, things change and we need to be creative about other funding mechanisms. We've done a lot for community hospital foundations with motivational messaging to promote colorectal cancer screening and seen increases just by putting in a couple lines of text that have been tested in rural communities that are shown to be receptive and can increase colorectal cancer screening rates just by putting those in the provider gap letters to patients. So I think we should be thinking about cost-effective, sustainable solutions too, as opposed to these grand ideas that might be great and be able to be supported by large grants, but will not be sustainable long-term after the grant funding goes away.
Particularly if the grant money gets impounded somehow,
Yes.
somewhere. Tricia, what do you do? What are your communication tools? What are your favorite tools in the toolbox
So,
to get your word out?
well, I would say, what Monica was talking about, listening more than talking, and grabbing your physicians in the community to help move some of these things forward. And I think one of what's happened in medicine is we've gotten so dependent on the technological advances, the pharmaceuticals, the surgeries to
We
solve
love silver bullets, right?
all these silver bullets to solve the problems. And we have physicians treating people like they're a problem or an organ or a lab, and so we're not thinking about our people as whole people. And I think so advocating for yourself with your physician to treat you as a whole person. And I think that's one of the big things I'm pushing for right now with my elective at the University of Utah is trying to just start building it into the fiber of education. Physicians should think about the whole person. They should think about using lifestyle factors, nutrition and exercise, sleep, connection to move the needle and know that all those things are part of treating a whole person, understanding the social determinants of health, and getting that education as how we can help a patient get through an illness or prevent an illness, because otherwise we suffer as physicians this moral devastation of knowing there's something that could help this person and we don't have the tools to do it. And so until we bring back the physician to treating a whole person and being integrative about our whole approach to medicine, we are going to lack those resources in our community. And I think part of it is getting the psychology department, the social work department to teach our physicians how to do motivational interview. We don't have to, we have so many resources in these big universities. There's the College of Health, and there's the College of Social Work, and there's the School of Medicine, and they all are professionals. And as we collaborate and learn from each other, we can churn out physicians who are treating a whole person and bringing health back into healthcare.
Go ahead, Bill.
I just wanted to add too, the other day I responded to something online and we were talking about, who's involved with cancer prevention at the cabinet level. Every member of government is involved with cancer prevention. We need these people, whether it's from like the EPA, Health and Human Services, every area, everybody's got a role in what we do. That's what a big, cumbersome job this is and why the conversation is so critical. Who brought up relationships? You, Monica? So I don't know if any of you know this, but Less Cancer is all about relationships. We've had over 5,000 donors. We don't take money from conflicting organizations. We are a bake sale organization. We don't have big grants. We don't have that. The great thing about all of that, it's not great as an organization always, but the great thing about that is we have many relationships who care about what we care about because we are listening to them and we're working to meet their needs. We're working to end the suffering that is associated with cancer. And so I think these relationships, thank you for verbalizing it, are super critical in understanding how we're going to meet people's needs. So that was it.
So you go ahead, Linda.
Quick thought for my next generation over there. If you feel comfortable This is a great time to write your members of Congress, your House rep and 2 senators, and thank them for cancer prevention. Comment on Bill's wonderful Less Cancers workshop, but open the door that cancer prevention, if it is important to you. And you hope that they'll stay on the right side of science. Not exactly in those words, but talk to your lawmakers, because you, as the next generation, you will be heard.
When people hear messages, they make change. And when they come from a young person, it's powerful, and they listen to those letters. So, great idea.
And if you need help, grab me. I'll help you, okay?
Knowing how to, like you mentioned, Miles, how to transition a farm to making what they call specialty crops, which is any other vegetable besides soy, corn, and wheat, and how to get that to people. So I think it just depends on how it's rolled out and how we get back to. Certainly, as we've mentioned many times, that prevention hasn't been prioritized, and if we get to the result is to prioritize in an effective way prevention, I think that would be.
Let's go for the glimmer of hope here.
Yeah.
Linda, you see a glimmer. How will this change the way
trying to
you?
get the worm out.
Are you manning the barricades, or are you retreating?
We only have one way to go, and it's forward. So we have to develop. It's going to be advocacy 2.0. It'll be more creative. It will be big gratitude followed by deep concern letters, and don't underestimate social media for anybody over 35 back there. These young people have it down, and I hope you guys are tweeting in TikTok later that you did something. Yeah, don't shake your head. Say yeah. But we're going to be working on building, strengthening our relationships. I'm sure the International Association of Firefighters and ADO will have a letter that will go to RFK. His family was always built around cancer prevention, so we'll be reminding him about that. But just crying, it doesn't work. And being angry also doesn't work. You have to be creative, strategic, and persistent, I think, in the world that I work in, and just knock down those barriers, because no one's going to open the door for you, not in this, unfortunately, not during this tumultuous time. And everybody benefits from each one of you being here today by commenting publicly about attending Less Cancers workshop. And you didn't pay me to say that.
Kelly,
One time, a few years ago, Linda, more than a few years before COVID, we were standing in the hall, and there were a whole group of legislators walking down the hall, and they saw Linda and myself chatting, and like 6 of them turned around and walked the other way. They just all pivoted and went the other way, because they've seen many of us at their door stop and have asked a lot of the hard questions. But these systems are not just reliant on government at all. We have so much within our power. We are all creative. We are all leaders in our organizations. We can do this, and we can do this on a lot of levels that may not be of the norm. This year we have a bit of a smaller crowd by design, because we didn't really understand what was happening in this climate. And we wanted the conversation to be much more intimate and connected, so people would come away with some powerful information and powerful change.
you were talking about research earlier, and the challenges that pre-exist on funding are tremendous. The number of proposals that get funded is a tiny little fraction, and so a lot of good ideas never get run to ground. And now we have a much more draconian kind of impoundment. What's that really going to mean in the real world? We're going to have immediate impacts, long term, or all the above?
For me, this last couple of weeks has been a nightmare. I mean, data sets that were publicly available are just not on the websites anymore. I'm doing work to understand the role of social vulnerability index, which is a county level measure on cancer outcomes, and I can't get that data set anymore.
Is that CDC data that has been taken down? And was that for DEI reasons, or what was the?
I don't.
Same with things like HIV prevention. Some of those things we'll be adding to the Less Cancer website because they're now down on government sites. And so that's unfortunate. but it will be resolved. Unfortunately, when some of this aid falls off, we have many lives that are lost, and it isn't without consequence. But when we were founded, like all of you, it was less cancer for everybody, even people that don't think like us, look like us, act like us, and that's what I'm sticking to, right? And so, yeah, it's unfortunate to have these gaps in information, but we're going to catch up. They're going to be on our websites. We're going to keep it going.
Any questions from the audience, by the way? Some of these young shining faces here. Do you have any thoughts for us on how to communicate? Because they know how to do it better than we do.
You want to call these guys who you are?
We caught her in the middle of a. Yeah.
Hi, my name is Ruth Travis, and I am an 18-year breast cancer survivor.
All right.
I wear a lot of hats. I'm a retired pastor, I'm a retired high school teacher, athletic director, and coach. But I work for the University of Maryland Cancer Center as a cancer health ambassador. And I have put together a project that I call Love Me Some Me to put into a Black community that's in Baltimore City. And I'm going to train 5 members from 5 different churches how to be a cancer health ambassador. I'll create some nice name for it. Because I think that these pastors should know that people who live next door to the church are dying because they're not being screened. And a lot of it is because they don't have the information they need to take better care of themselves. And so I'm excited. Anytime I don't even know how I found out about you guys. I saw it somewhere. If it says cancer, I'm going to be here. I drove over from Baltimore. I parked on 6th Street. I walked up to this building.
All right.
And this is phenomenal. I'm enjoying myself. I really am. Thank you.
You contact us about getting help for your church. We did an event with a coalition of African American Baptist churches in Virginia around prostate screenings. We did an event there, and from that event, I think there were 2 or 3 diagnoses of prostate cancer, and lives were saved, boom, just from that one conversation, and those wives who drove their husbands to the doctors.
Yeah, I'll just comment on it. I mean, so definitely, faith-based organizations have been wonderful partners, and especially in communities where there are issues. I think a couple of people mentioned about mistrust. That's a fantastic way to, have a trusted leader to have conversations about that. So absolutely excited that you're getting that program going, and we can talk offline about, how, I could even potentially support you in that.
And I joined I have a nonprofit, Ruth Pink House, and the donations that use to help those who have breast cancer, I take them grocery shopping. I just paid a lady's rent yesterday. And so if I was not diagnosed with breast cancer, I wouldn't be doing this.
Sure.
Because I didn't have a problem when they go in for the surgery. I wasn't worried about my mortgage being paid. I got good health insurance. I had salary from the church. I had Social Security. I had pension from teaching. So now working with people who don't have those resources,
Yes.
I get teary-eyed because there's so many of them. Yeah, so many.
Thank you for doing what
Thank
you do.
you. We have a question back here, Mom.
Yeah, question.
Yes, thank you very much. First of all, I want to appreciate you for this event. And I feel that my voice might have been interesting for you because I'm mother of 4, and I've been here in America for 1 year. And I've came here from war-affected area. So what I've seen here, that is just amazing. I mean that, you've discussed some such kind of aspects for cancer prevention, like physical activity, HPV vaccination, and veggies. And I would say that personally for my family, that is just amazing that there are so many bike routes and trails, and we are just riding around without any stop, and we do a lot of sport, and I feel more healthier than I've been before. That's true. And about HPV vaccination, I think that my daughter, she got this vaccine, and that was obligatory for her. And I believe that it also was a great, just a great fortune for me, because I was trying to do that vaccination in my home country, but that was not available. And also about veggies, I would say that this area is just fruitful for veggies, and that's really like, there's so many aspects which might be covered here, at least at DC, at Arlington area. And like, what I see, you are trying to put some kind of responsibility to young doctors, to physicians. Being a mother, I would say that I would start with a kind of education and even a kind of indoctrination for kids at school, because it really comes from your very, very young ages. Like, when you started with that, it's really hard to quit, like riding bike or eating healthy or something like that. And I feel that if you start just with doctors and physicians, that might be too late for for whole population. That is just my voice, and I hope that it might be helpful for you.
Thank you very much.
Everybody's voice is important.
Hopefully that voice gets heard.
Do we have any questions?
I work with for-profit and nonprofit in the food industry, and during COVID, it was a great opportunity for the for-profit, which are mostly restaurants, because they weren't doing anything, to partner with the nonprofits. And they started going into the inner cities to feed people and offering free meals and whatever. What they discovered also in the process is that a lot of the schools, which were the great point for intervention, because most of these kids only eat in schools, no longer had cafeteria. They had cafeterias, but they had microwaves. And the cafeteria workers only knew how to work a box cutter. They didn't know how to cook anything, because everything's through microwave and whatever. So they have since all been able to get involved with the schools and change that. And they've had to do training sessions on knife skills and all kinds of things. In fact, they're working right now in Faulkner County. They've moved from inner DC out into the suburbs around the DC region, and they're able to, we've been able to partner farms with them too. DC Central Kitchen is doing contract farming, and now so are a lot of schools, so that you can make the intervention at the school level with these kids and start teaching them that it's not all frozen pizza. And that's been helpful. It's been very cost effective.
Do they still have soda machines in the cafeterias? That's good. That's good.
That's really phenomenal.
That's great to hear. It really is.
The
Go ahead.
Teaching Kitchen Collaborative has some school members, and I wonder if your community is part of the Teaching Kitchen Collaborative, but that we are sharing resources like that, like hearing those stories and moving that through the country is critical, I think, because both of you are right. The kids are where we need to start. Thank you.
Cancer centers in this country with fast food restaurants in their lobbies. And things that don't make sense. They're big disconnects. So we're grateful for those schools.
What's your favorite one? The pink bucket of Kentucky Fried Chicken?
Yeah, I don't want to name names because I'm working on changing them.
Cognitive dissonance is what that is.
I want to make sure we can work with people to change them. Sure. And so those are a lot of conversations for me they're sick of. So go ahead.
Linda.
Okay, I'm going to share a secret. I'm going to give you guys the insight into my clothespin strategy 2.0. Sometimes you just have to pinch your nose when you're looking for a new partner or collaboration. And I have had to work with industry who have imported and used asbestos, and they now support legislation. So as we work on where we are now with HHS, I encourage you to do Clothespin 2.0. Look where your next partner could be. How can you offer your resources? And like the woman in the back that just shared, sometimes working with industry, I used to bristle and really say, no, I can't do that. It violates my integrity. And I've learned after 20 years, you better buck up, join the party. You don't have to compromise your integrity, but a clothespin works very well sometimes.
You don't compromise when you don't take funding, because funding always requires some messaging shape. So it's critical to work with these companies, some of them, and see what you can do to bring change about. But I think the big lesson here for students and for grown-ups, adults, all of us, is learning to work with divergent thinkers, learning to get along and have a relationship enough so you can say, hey, you who thinks nothing like me has the policies that are crazy, lunacy. We got to figure this out. How are we going to do it? And those conversations happen by listening and connecting and continuing to look for a team. And in this case, it's less cancer for all. It may be something else for you guys.
Yeah, thank you guys for being here, first of all. Thank you so much. I'm very glad I heard of this opportunity and I couldn't miss it. My name is Samra Smadi. I am a student at Georgetown University getting my master's in environmental metrology and policy. And so that's a program that combines toxicology, chemistry, and policy all together. So I'm very happy to be here. I guess I really resonated with everyone on the panel. I'm from LA as well. I studied epidemiology last summer at NCI. I'm very community oriented and, get nervous.
It's all good.
And food health is very important to me, and nutrition is, all of that connects, everything connects. I guess my question is, there's so much data out there, and so much data we don't know what to do with, and we don't know how to sift through it, especially as a young generation. There's a lot of barriers, and I guess what do we do when it comes to the amount of information, and how do we find out what to do and how to advocate in the best way? Thank you.
Do you want me to start that?
Yeah, why don't you start?
I think it's such a big, prevention is this giant net. Where do you start? It's too much for me to think about. It's blah, blah, blah. I think for advocates, you're going to be an advocate. You're a scientist. You're going to have a degree. You're going to be a leader. You're going to have your niche thing. It might be water. It might be cancer. It might be the air. It might be poverty. It could be any of those things. But whatever you feel most is what you should follow. But you need to make sure the science is there to guide you, that we have that accurate information. So, where do you start? Where do you pick out, the information? I was in my 40s when I founded this organization. I did a lot of marketing for big communications companies, making sure lots of people drink Coca-Cola and ate Chick-fil-A. And I had to change my life, and I was very focused on it. But it happens to be this big net of conversation. But we know the work of Less Cancer, for instance, has changed the landscape of cancer conversation. Less Cancer, when it was founded, literally, cancer and prevention were barely words that were ever put together, never found in the same paragraph, much less book or anything else. So I do know time's not on your side, Miles, and we do want to wrap up, and I want to make sure all these people get a sandwich and something to eat.
Yeah. If anybody else has any questions or thoughts, do you guys have any final thoughts you want to share? Any takeaways for these fresh faces? Go ahead.
Real quick, as Bill's walking over,
Go ahead.
I also want to say, I think as younger people, I happen to have 2 young adults in my family. I think it's go to your primary sources for your data, making sure that you're looking at multiple primary sources. I also say look at some counterfactual sources as well so you can understand and distill it down to something simple. I think my colleague talked about TikTok and social media. Your generation does a fabulous job of just getting it down to 30 seconds or 60 seconds. I think that's what's going to be much more powerful. And while many of us like the data, it's usually the stories that actually move the needle. So that's what I would encourage you to think about.
The short stories.
Yes.
Here you go.
Thank you all for being here. As you guys have touched on the importance of physical health and eating right for cancer prevention, how do you think mainstream dietary drugs such as Ozempic will impact cancer prevention and the rates of cancer in current day?
Should we take the pill?
Take a
I think
stab
I
at
asked this
one.
question. I've been asking my doctor. She's
Tried to
been giving
avoid
me
that
the
question
stiff
earlier.
arm.
Thank you for asking it. So there is a role for these medications. The pathway is well known, and they've been shown to help people with insulin resistance and making some difference. I think as well, and we have completely opened the floodgates, and it's accessible to everybody, and it's basically overprescribed. I'd say we've had other medications overprescribed in the past, proton pump inhibitors, those acid reducers. We now know there were some big fallouts from those in terms of other side effect health problems. And I think we're going to find the same with GLP type medications like Ozempic. I think one of the big problems with them is the weight loss happens not only for people's fat, but also their muscle. And as we age, it's really hard to build muscle. And when we have less muscle, we're not as resilient in our health because we can't balance our blood sugars as well. We can't, our metabolism slows down because our muscles require more energy to keep going. So we want to keep muscle. So guiding people to, I always say you can't out supplement or out medicate a bad diet. If you're not doing, taking health preventive measures with nutrition, with physical activity, movement, with consecutive restorative sleep, with connection, and I think that's one of the big pieces of we haven't chatted about. But we talk about food as medicine. We actually it's within this whole integrative approach of these different modalities, and without those things, without a physical training program, trying to keep up as much muscle as you can as people lose weight, the fallout I think is going to be big. I think, and I have had patients, some will come in and they'll do my nutrition class and they'll get a foundation of understanding health, and they've really shifted how they live each day. And then they'll feel like also they want to lose weight and take GLP-1s, not under my guidance, but that's what they do. And my sense is they'll do better than the other patient who comes in to tell me, finally, it's been my whole life and I've never been able to eat donuts and now I can. And so that person's not going to fare that well, probably have a lot more inflammation, a breakdown in the protection of their immune system, and potentially higher cancer rates. I think that's where I see it going.
Just quick anecdote here. I have diabetes, and one of the first medicines they used on me was Ozempic. And for years I was able to avoid meds through exercise and diet, but with age comes a weaker pancreas, your organs get weaker, and so they had to put me on meds. But the Ozempic, I gained 10 pounds. It didn't do anything for my A1C. That said, it's just not a perfect bullet for everybody, as Tricia alludes to, but it is also helped. Like, I'm pretty careful about how I talk about it because I've seen people transform their lives. They've transformed their diet, they've transformed how they live, but things like their knees that never worked, they're now running more. So it's a really case-by-case thing. And I personally was super hesitant to start any meds. I'm on a couple right now. And my body needed it. And I've lost a lot of weight to not have to do it. And then 5 years later, still had to do it. So, it's case by case. It goes back to relationships. There's not one cure, one switch for anybody. Go ahead, I'm sorry.
All right, any other final thoughts that you guys want to share from the panel that we left unsaid? All right, you guys are great.
Prevention is the cure. And if you think that you want to make change happen, talk to one of us. We'd be happy to have like 1 minute, 1 hour, 1 week. Advocacy isn't scary. Just open the door and ask questions. We'd love to hear from you.
I want everybody to get some lunch.
Yeah, great way to end it. Thank you all panelists. Thank you all for your great questions. Bill, thank you for all you do with less cancer.
Hi, everyone. I'm Congressman Chris Pappas from New Hampshire. Sorry I couldn't join you in person, but I'm glad to be able to appear before you to stress the importance that education and advocacy holds in reducing the risk of cancer. Thank you to Less Cancer's Board of Directors for your dedication to this cause, and for all the organizers, including my friend Mindy Messmer, for making this event possible. Less Cancer uses 3 approaches to address cancer prevention: reaching out to the public, advocating for change, and participating in public discussion. National Cancer Prevention Day combines all of these approaches to raise awareness and reduce cancer risk in our communities. And I want to thank all of you for joining today to continue that work for that goal. In my state of New Hampshire, we have some of the highest cancer rates in the country, and we have significant concerns that are ongoing about PFAS contamination in our drinking water and the connection to cancer and other chronic diseases. As a member of Congress, I've led a range of efforts to secure clean, safe drinking water, to work with my colleagues to reduce cancer and to increase prevention. I've led efforts to hold PFAS polluters accountable and ensure that our communities have safe drinking water. I helped pass the Honoring Our Pact Act, which expands health care for veterans who are exposed to toxic substances. But there's so much more work to do to make sure that Americans can stay safe and live healthy lives. So I look forward to continuing to work with Less Cancer to reduce cancer by highlighting prevention. And I want to conclude by just saying thank you. Thank you for sharing your stories, for devoting your time and effort to this worthy cause. And thank you for standing up for your families and your communities as we work toward a world with less cancer. Thanks so much and take care.
I'm Don Beyer, and I represent Virginia in the U.S. Congress. And I'm honored to welcome you all to this year's National Black Nurses Day on Capitol Hill. I want to thank you for being here today to lobby for critical legislation to help nurses, to support the next generation of care workers, and eliminate healthcare disparities. My sister was a nurse. My mother-in-law was a nurse. I have wonderful nurse friends here representing us in the U.S. Congress. We need your voices. You're the backbone of our nation's healthcare system, and you have the profound expertise in delivering the care that the American people need. Your work has made incalculable improvements to the well-being of every American. But there's still work to do to address ongoing threats and challenges. I'm proud to support your work to make real improvements for every American. I'm a proud member of the Black Maternal Health Caucus, led by my wonderful colleagues, Congresswoman Alma Adams and Congresswoman Lauren Underwood. To put that work in action, I lead the Improving Diagnosis in Medicine Act. That's a bill that supports healthcare workers in reducing diagnostic errors that persistently and disproportionately impact certain groups, including and especially Black women. Tragically, Black women face misdiagnosis and late diagnoses of childbirth-related conditions at dramatically higher rates, leading to higher rate of preventable lifelong impacts. Look, we have a responsibility to act to end that crisis, and I'm proud to lead legislation to address our nationwide nursing shortage. Our healthcare system cannot operate without highly skilled nursing professionals. And I'm deeply concerned that we continue to see acute staffing shortages driving burnout, leading to a compounding cycle years after the early days of COVID. You know, the burnout didn't end with COVID. We urgently need to break that cycle and ensure that we have a nursing workforce free from shortfalls and that properly represents the diversity of our country. Along with those urgent priorities, we need to make sure that our healthcare system is prepared for the next wave of challenges and opportunities. And I'm delighted that your priorities this year are looking forward to those challenges. Climate change remains the existential crisis of our time, and one whose effects will continue to fall disproportionately on the most vulnerable Americans. Seeking out climate solutions is an indispensable part of fighting to end health disparities. I've also been particularly focused on the impactful applications of artificial intelligence, AI, in healthcare. So I'm glad to see that this is also a priority for you. I was amazed to learn that working with AI, scientists have been able to improve their identification of early breast cancer mammograms by nearly 3%. We need to make that 50% or 100%. And other AI-powered diagnostic technology can be used to quickly diagnose diabetes retinopathy, which is the #1 cause of blindness in patients with diabetes. With early diagnosis, we can help people mitigate or prevent severe vision loss. These are some of the excellent diagnostic examples, but they're only part of the very exciting growth and innovation across medicine. However, a major downside of using any AI model, apart from data privacy concerns, is that you got to be very careful that the models don't perpetuate inequity. As they say in computer science, garbage in, garbage out. If our model only trains on like a subset of white men, then the model will only output results that apply to white men. But when you bring this to healthcare, you have the same problem. Health resources are often not provided on an equitable scale for many people of color in America. For example, as I'm sure you all know already, a 2016 study found that many medical textbooks contain unequal representation of men and women and by skin tone. 78% of the images that were studied depicted a white skin tone, only 22% depicted people of color. And when we train AI models on that flawed data, we're just perpetuating underrepresentation. So while we should be excited about the incredible developments in health and AI, we also need to account for the technology's shortfall and protect all Americans from adverse impacts. We need thoughtful bills, like my Create AI Act. It's bipartisan. We thoughtfully support this technology while being cognizant of AI's risks. And I'm so glad to welcome you all here to take part in those conversations and to advocate for real solutions. Thank you, and good luck on a successful day on Capitol Hill.
Hi, everyone. It's Tom Barrett, and I represent Michigan's 7th Congressional District. I know this week we commemorated National Cancer Prevention Day. And here in Washington, D.C., I want you to know that we are very focused on all the efforts we can do to help prevent and find cures and therapies and treatments for cancer. Every one of us has been deeply affected by this, either by ourselves or close family members, friends of ours, and others that we know so closely. This is a fight that we continue to endure and one that we are committed to doing everything we can to keep Americans healthier, to get preventative treatment, to get screenings done, and to find therapies and cures that will work for you, your family, and our loved ones to really prolong our lives and help defeat this disease. Thank you so much for the work that you're doing, and look forward to continuing that progress going forward in every way that we can. Thank you.
Hello, and thank you all for being here today to raise awareness and rally around this important topic. The C word has a way of sparking fear in the bravest hearts and zapping strength from the strongest among us. It knows no age, gender, color, or level of physical fitness. Cancer can sneak up on anyone, sometimes regardless of lifestyle choices or hereditary dispositions. That's why it's imperative that we all act in preventive ways to ensure that no one will have to endure this disease blindly. It's by arming ourselves and our loved ones with knowledge and early detection that we can truly overcome the obstacles and struggles that the C word causes. I believe everyone knows someone who has been touched by this difficult diagnosis, and that's why I remain committed to fighting the ugly disease anywhere it rears its ugly head. We must keep seeking new pathways to treatment and put in place the legislative support that the structures necessary so that one day no one will ever again have to hear the C word.
Hi, Congressman James here. I wish I could be there with you today because this is a truly critical conversation. Nearly everyone's been impacted by cancer or knows someone who has. It's a devastating disease that we must continue to combat in all of its forms. This is a personal issue for me. I've had family members who've gone to be with the Lord after courageous battles with cancer just in the past couple of years, and I know that there's so much more that we can do for their memories and also for people who are still living, who are desperately counting on us to reduce the risk and improve treatment. We cannot allow cancer to continue wreaking havoc on our nation's health. I'm so proud to be a co-sponsor of Congresswoman Dingell's resolution to recognize February 4th as National Cancer Prevention Day. This will play a critical role in prevention, which isn't just about risk reduction, but also about improving quality of life. Raising awareness for this deadly disease is both in the best interest of American people and the health of our nation. Not only is a healthy America a strong America, it's vital to our national defense as well. Cancer prevention both saves lives and also reduces economic burdens on our healthcare systems and fosters healthier, happier communities. It's in our national best interest, morally and economically, to do the right thing here. Know that you have an ally and a friend in this fight to stop cancer. God bless you, and thank you.
Thank you, Less Cancer, and everyone here for your advocacy for cancer research, and as importantly, your work for finding cures for cancer. Your advocacy has never been more important. As you know, the Trump administration has made certain threats of cuts in cancer research and pause of funding in cancer research. We need to say that this is bipartisan in this country. We need to fund cancer research. We need to make sure that we have a moonshot for cancer research. And I look forward to working with you to make sure that our researchers are funded, that the programs are not cut.